Thanks for having me. I'm Ali Husain from the Division of Nephrology at Columbia, where I'm a transplant nephrologist. And today I'd like to talk to you a little bit about how the COVID-19 pandemic has influenced the supply of deceased donor kidneys in the United States and how it's kind of changed the way we think about deceased and living donor organ selection. I have no conflicts of interest to disclose, and my funding is listed here. So basically, I'd like to talk about the following things in turn. So first, we'll just talk about generally the impact of COVID-19 on the availability of kidneys available for transplant. We'll then talk about kind of three different types of donor situations. So first, donors with known active COVID-19, then donors who have had COVID-19 but recovered, and then finally, potential donors who have no history of COVID-19 but who we wish to evaluate for the infection before we allow them to donate. A few disclaimers before we get into the content. One is to remember that the evidence I'm presenting here is really, really limited, and the situation is really rapidly evolving. For your context, we're recording this talk in early December before vaccine rollout. So there's always a chance that in the next several months, especially after the vaccines have been implemented in the United States and abroad, that some of this decision-making will change. But I think most of the fundamentals of the concepts we'll talk about should stay the same. So I want to start out with just kind of laying out a conceptual framework of how we should be thinking about things. In general, when we're evaluating what we should do with a patient on the wait list and deciding whether it's safe to proceed with transplantation during the pandemic, we want to look at this framework here. And kind of ultimately, we want to decide, if we transplant the patient versus ask them to remain on dialysis for a patient who's not preemptive, is it more likely that through some combination of their likelihood of getting COVID and living or dying from COVID, and some combination of not getting COVID and living and dying from something else, do those probabilities outweigh each other to favor transplantation or favor staying on dialysis? So in order to decide how we should evaluate donors, we need to first focus briefly on this first part, for which there's probably the most evidence out of all of these. And there's basically been just two case series cohorts of waitlisted patients and transplanted patients, of which I'd like to present data from one. So here is a kind of cohort study from London, England, looking at transplant patients versus waitlisted patients during the pandemic. And these investigators looked at 299 waitlisted patients and compared them to 237 patients who had just recently been transplanted right before the pandemic hit, and looked at their overall survival for a follow-up time maximum of 68 days. Not only did they identify which patients did not get COVID based on nasal swab testing, they did a sensitivity analysis where they repeated the COVID-19 identification using antibody seropositivity to kind of retrospectively identify any asymptomatic cases. So it's pretty robust analysis. What you're seeing here is the survival curve of overall survival from start of follow-up to end of follow-up. And you can see that the overall survival was similar for patients who were transplanted and those who were remaining on the wait list. And when we dive into that a little further, you can see that the reason those survivals were the same was really different between groups, and survival is really conditional in each group. So we'll see that kind of on the left here, you can see the proportion of patients in each group that remained COVID-free. And you can see that the waitlisted patients were much less likely to remain free of COVID as time went on, whereas the transplant recipients were more likely to stay free of COVID. On the other hand, on the right, you can see that once any patient actually got COVID, the transplant patients were much more likely to die than those who were on the wait list. So it seems to be some combination of waitlisted patients having more exposures, especially if we think about patients who have twice weekly maintenance dialysis, so maybe more likely to contract COVID, but transplant patients perhaps being more susceptible to severe disease and death. So even when they adjusted for screening bias, they found that the hazard ratio for death once COVID was diagnosed was greater than 3 for patients who are transplant recipients compared to those who are on the wait list. Important things to remember that this doesn't take into account things like quality of life, kind of the long-term impact of having a backlog of missed opportunities for transplant, and the long-term survival, 6 months or a year from now for patients who remain on the wait list. But overall seems to suggest that, our imperative while we decide whether or not we can safely continue transplant, is to focus on reducing the risk of contracting COVID-19 among transplant recipients. And kind of there's two areas of focus that we can think about. So one is getting COVID from the donor, and that's kind of going to be the focus of our talk today here. The other is getting COVID from someone else, kind of after transplant. We won't talk about that today, but I think it's kind of a whole talk in and of itself. When we think about protecting transplant recipients from donor-related COVID exposures, we need to first think about kind of what the overall organ availability landscape has been like since the pandemic began. So looking at our transplants to date in the United States, we can see that overall there's slightly fewer transplants of kidney transplants performed through the year so far compared to last year. This kind of basically equivalent number is primarily driven by a slight increase in deceased donor transplant that's offset a marked decrease in living donor transplants. If we zoom in a little bit more to the kind of the early pandemic period, which I think is where kind of the most interesting stuff was happening, you can see that there was a pretty steep drop off in number of deceased donors recovered, deceased donor kidney transplant performed in early March and mid-March. They started to recover in late April. You can see that during that time, March, April, and May, the number of living donor transplants being performed almost completely came to a halt. Deceased donor transplants, which had been greatly outpacing the year prior, kind of returned to similar numbers as the year prior. And that's something that's a little bit unique to kidney transplants. So this is data from investigators in France and the United States looking at organ recovery and transplants performed. And you can see that the blue lines on the rightmost panels are transplanted kidneys, and the other colors are other transplanted organs. You can see that there's a much steeper decline in transplanted kidneys than there were in other organs. We'll talk about why this might be a little later. But even among organs that were recovered, utilization was greatly impacted. So here's data from Live On New York, which is actually the organ procurement organization that represents my DSA. And you can see that despite the fact that organ recovery had slowed down, the number of kidneys that were procured and subsequently discarded reached a peak of over 70% in April. And that's kind of in these hotspots. So the concerns that were driving this, in addition to donor transmission, which is what will be the focus of the rest of this talk, were things like resource availability in terms of staff, operating room, PPE, as well as the concerns of using and utilizing resources that might need to be kind of more urgently used for other patients. But when we're thinking about these donors, we really want to think about three potential conditions that they may have. And this is kind of an exhaustive list of every donor you could possibly see. One is that they have COVID-19 that's known and active. The other is that they are known to have COVID-19 in the past, and they're considered to have recovered from that initial infection. And the final is that they have no history of COVID-19 that we know of. So we'll talk about each of these in turn. Importantly, we will not talk about the donor perspective in terms of safety. So, is it safe for a living donor to donate? And only focus on kind of donor evaluation from a recipient standpoint for the rest of this talk. Although that donor perspective is obviously very important, especially considering that living donors are doing a very altruistic deed. But starting with donors who have known active COVID-19, we know that the recommendation from the American Society of Transplantation and the American Society of Transplant Surgeons are both against considering transplantation of organs from donors with active COVID-19, which probably should come as no surprise to most of you. There's been multiple reasons offered by the community for why this should be the case for potential kidney donors. These include the likelihood of the kidney as a potential site and reservoir of infection. The evidence for this has been growing despite some controversy, and is based on things like demonstration of viral particles on electron microscopy of kidney biopsy specimens, viral RNA detected by PCR in kidney biopsy specimens, viral proteins detected, recovery of live virus particles in kidney tissue. So, if the kidney is a site of infection, it's likely that that infection will travel from the donor to the recipient with the kidney. In addition, kind of as I showed you earlier, there's this concern for high morbidity and mortality in immunosuppressed recipients if transmission does occur, so further favoring being much more risk averse. And then finally, for kidneys in particular, there's the thought that, we have dialysis, which is alternative and if needed to be temporary or permanent treatment, which might not be as true in other organ cases. But kind of as a community, I think most people believe that this favors kind of the exclusion of these donors from donation. Importantly, donor-transmitted infection has been demonstrated in other organs. So in liver, for example, here's a case of an infant who had biliary atresia. And her donor was her mother, who was found to be COVID positive on post-op day number 2. So on post-op day 4, the recipient developed respiratory distress, fever, severe transaminitis, and was also found to be COVID-19 positive. After that time, kind of the liver biopsy showed hepatitis, mild to moderate acute cellular rejection. Ultimately, the outcome was okay, but clearly there was concern for donor-derived infection. Although we also kind of need to wonder about whether perhaps, since it was a mother and child living together, there might have been some exposure before the time of the donation as well. That being said, not everyone believes that we should be saying a blanket no to using organs from these donors. So much of the kind of the thought leadership on this area has been from Olivia Cates, who's an infectious disease specialist at the University of Washington, whose work is really interesting. And I really recommend you reading these 2 personal viewpoints she wrote in AJT. But she's kind of provided an alternative argument to focus on the safety versus risk of stopping a transplant. And we'll get to her specific recommendations in a second, but the thought that perhaps we can safely use these organs comes from indirect evidence from a few other case reports. So here is a case of a 21-year-old man who had aplastic anemia that was requiring platelet transfusion from an individual who was subsequently found to be COVID-19 positive. So the donor was asymptomatic at the time of blood donation. 2 days later, the platelet transfusion occurred, and the following day, the donor had become symptomatic and tested positive. The recipient of the platelet transfusion was followed for over 2 weeks, was persistently COVID-19 negative. And the thought was, perhaps this means that transmission via blood products at least is not inevitable. Although it's important to remember that the donor was asymptomatic at donation, so there's a question of whether or not he was kind of transmissible and had sufficient viremia at that time to transmit or not. So clearly not definitive evidence, but certainly thought-provoking. In a similar case of a 57-year-old man with relapsed mantle cell lymphoma who had a hematopoietic stem cell transplant from his sister as a donor, we see a kind of a somewhat of interesting picture. So in this case, the sister donor was living in Brazil, traveled to Spain to the recipient to start mobilization. She's asymptomatic during the travel period, asymptomatic during her medical examination, and at the time of the apheresis. And shortly after the transplant took place, she became symptomatic and tested positive. The recipient stayed negative throughout the entire time, which was excellent, so suggesting, again, maybe transmission is not inevitable. But again, if I think about, at the time of donation, was she actually positive or was she perhaps in an incubation period? Importantly, this also kind of is a good reminder that this is someone who was engaging in a high-risk activity, right? She was taking a transcontinental flight. So that should perhaps kind of ring some alarm bells in our head of perhaps we should deviate from our standard screening in some cases like this, or institute a longer waiting period. And the final case report kind of that seems to suggest that maybe we should always just be saying no to these donors, comes again from liver. So this is a healthy, live, living donor who donated to a family member. And this young woman had a mild febrile illness without any respiratory or GI symptoms 1 day prior to donation. 2 days after the procedure, she was informed that she had had a close contact with a COVID-19 positive individual shortly before donation. She had positive COVID-19 testing on post-op day 3. The recipient never developed symptoms, never developed fever, and persistently tested COVID-19 negative. At the time the recipient was treated with hydroxychloroquine and lopinavir-ritonavir combination, which we now know don't do anything. So those are unlikely to be the explanation of why transmission did not occur. But again, just some evidence that perhaps in certain cases it's not necessarily inevitable. Again, this evidence is extremely weak, so I don't want your take-home point to say, okay, it's safe. But I think Olivia Cates kind of summed up nicely here. I left this whole slide here for all of you in case you want to review their full recommendations. Feel free to pause the talk for this. But I think the important part here for us is highlighted in red, which is that although this seems like it might be safe, the risk-benefit calculus probably more favors considering this kind of donor use, so donors who have COVID-19, primarily for organs like liver or heart transplantation, who have a really, really high estimated waitlist mortality and a low probability of a kind of really quick and non-infected match. For the reasons we discussed earlier in kidney, regarding the suitability of dialysis as a potential short-term alternative therapy, it probably does not yet make sense, although we'll have to see what the impact of vaccination will be on that decision-making. It'll depend on a lot of things, the degree of immunity, the reliability of immunity, the ability to take titers, et cetera. But for now, I think that kind of everyone's in the transplant community is in agreement that for kidney transplantation, we do not want to be using donors who have known active infection. In contrast, it seems to be safe to use kidneys from donors who have recovered from the illness. Here, the evidence is surprisingly even less than what I just presented to you. But as far as the AST guidelines, they recommend that these donors can be considered under the following circumstances. Again, I left the entire text here for you to refer to, but the bolded areas we'll talk about quickly now. So their proposed criteria is that the repeat nucleic acid testing is negative. Symptoms have resolved and the initial infection occurred at least 21 days prior. They suggest that positive PCR testing within 90 days of the initial illness probably reflects persistent viral shedding in a patient who's had complete resolution of infection. So likely safe, but that since repeat infection has been documented, any positive PCR test after 90 days should be considered potential true positives and warrant for further investigation, and probably holding off on continuing with transplant. There's only one case series published on this topic. So this was a recently published a survey of 28 OPOs. So that's just about under half of the OPOs in the country responded to the survey. Of those that responded, only 3 reported they had transplanted organs from donors who had recovered from COVID-19. For the remainders, 2 OPOs said that they had unsuccessful attempts, so no transplantation occurred, and the rest of them didn't even have any attempts or experience trying to place or transplant these organs. So interestingly, of those 3 OPOs, they transplanted organs from 6 donors, 3 of whom donated both their kidneys. So 6 kidneys from 3 donors. In these cases, none of the recipients of any of the cases were found to subsequently be a COVID PCR positive, although 2 of the recipients never had any follow-up testing done. In only one of those 3 cases did the donor have serologic testing reported, and in that case, the donor was IgG positive. That's at case number 1 at the time of donation. So again, very, very weak evidence. These are donors who were around 2 weeks to 4 months out, but certainly suggestive that kind of our theoretical rationale about why this might be safe seems to be borne out so far in the small available evidence. So finally, the majority of people we're probably considering will be those without known COVID-19. And in these cases, we'll talk about our screening algorithm, but before that, we should think about the fact that there will always be some risk of donor-derived or donor-transmitted COVID-19, and that probability will really be proportional to the probability of the false of any test that's negative being a false negative test. And that probability of false negative testing depends on a few things, largely the base rate of infection, and that should be further stratified by on a patient level. So obviously the base rate of infection in patients who have known COVID-19 exposures, fever, shortness of breath, headache and nausea, no, that base rate would be very, very high versus obviously less in an asymptomatic carrier in a low transmission locale. And also the testing performance characteristics. When we think about the overall base rate of COVID-19 in any community from which we'll be kind of soliciting and procuring kidneys from donors, we get some evidence from recently published data. So here's a cross-sectional study that looked at the prevalence of COVID-19 seropositivity across all 50 states, Washington, D.C., and Puerto Rico. They used a convenient sample of lab specimens that were originally submitted to a commercial lab for routine screening clinical management. But you can see here they separated seropositivity out across 4 periods. So July and early August, mid-August to end of August to early September, and early to mid-September. Importantly, you can look at the age distribution here, which really covered all of the age groups from which we may kind of have donors who we consider for kidney donation. They found that the seroprevalence at a jurisdiction level over the 4 sample collection periods was anywhere from 1% to 23%. And in the majority of the jurisdictions, so 42 out of 49 that had sufficient samples to estimate seroprevalence across all the periods, under 10% had detectable SARS-CoV-2 antibodies. Changes from the first period to the 4th period were less than 7 percentage points in all the jurisdictions, but varied widely. And seroprevalence estimates varied between groups too. So it's different depending on participant sex, age groups, metropolitan versus non-metropolitan areas, et cetera. So for example, seroprevalence in people 65 and older was generally lower than seropositivity in adults aged 18 to 49. No need to pay attention to the exact text in these slides. I want you to only pay attention to the color. But this is seroprevalence estimates by metropolitan versus non-metropolitan locale. So you can see that the 3 columns for each time period go from metro to non-metro to overall. And you can see that generally metropolitan areas tended to have higher seroprevalence, although that's not the case universally. But again, these are the kind of things that we should be taking into account when we decide, do we trust a negative test in a donor? So if a donor is coming from a very highly seroprevalent area with a lot of active disease, who engages in any kind of high risk for transmission behavior, we might want to rethink how rigorous we want our testing to be, and if we will even be convinced by any degree of testing. It's not really the focus of this talk. I don't want to spend a lot of time talking about the different kinds of tests, but here's data from kind of a summary of different kinds of testing from the CDC about antigen versus PCR testing. And obviously PCR testing, as many of you probably already know, is our testing of choice for these donors due to kind of extremely good sensitivity and specificity of testing. Turnaround time is pretty decent. Part of our kind of trust of testing will also depend on the viral load kinetics. So here was a paper. Each of these panels represents a different participant. And you can see that these orange lines are sputum, yellow is swabs, gray is stool specimens, and these dark brown arrows are the time of seroconversion. And kind of the take-home point here is just that there's really variable viral load kinetics in terms of relationship to the start of infection, relationship to symptoms from person to person. So no testing we have will be 100% accurate, but I think we can achieve pretty good screening based on a few principles that have been kind of proposed. So the first is that donor PCR testing should be performed by upper and lower respiratory specimen swabbing, ideally within 48 hours of donation, but certainly has to be within 72 hours of donation. There are many proponents of doing a second test, so 2 tests within 72 hours. Kind of the value of this will somewhat depend on whether the testing error is random or systematic. But I think personally, I believe that a second test within 72 hours is probably appropriate before transplanting an organ to an immunosuppressed recipient. Donors with known high-risk exposure, so for example, that positive liver transplant living donor that we discussed earlier, should probably wait 14 days before donating, regardless of what the testing shows. And then some people, so for example, I know a center in China, kidney transplant center in China, also use other modalities like CT scans of all deceased donors to make sure they don't have any ground glass infiltrates. Personally, I think this is probably unnecessary, but again, something to consider because there's not really strong evidence for any of the things that we're doing. Overall, though, it seems that so far, given the lack of widespread donor to recipient transmitted infection, this seems to be an effective screening mechanism so far. And I'm looking forward to kind of the accumulation of more data to tell us whether this can be either modified or streamlined kind of to keep the transplant system running as we have second or third peaks. And again, a lot of this will be changed after we achieve widespread vaccine distribution as well. Finally, just a few additional considerations that we won't talk about in depth, but things to keep in mind. So one is the resource utilization and resource availability of performing, what many people consider to be an elective procedure during a pandemic. So, for example, in New York early on, even if we were able to safely do transplants, we probably would not have been able to just because of lack of kind of staff, operating room, masks, gloves, gowns, etc. We should also take into account the safety of living donors who are doing obviously a very altruistic deed. So bringing them into the healthcare system, having them interact with the healthcare system and potentially being exposed to COVID-19 is something we need to keep in mind. So we need to do this safely for them as well. Additionally, we have to worry about the safety of the transplant team. So the recovery team, the transplant surgeons, the nurses who have to have very close contact, anyone who's doing any counseling. We need to make sure that they are not having unnecessary exposures, especially at a time when overall staffing might be critical. And this includes best practices in organ recovery, really focusing on using local organ donation teams to reduce transit. And then finally, we need to put a lot of effort into making sure we continue to prevent COVID-19 transmission after transplantation, because that seems to be another big place that we can control donor to recipient transmission that will be important to kind of optimizing results for kidney transplant recipients during the pandemic. And then finally, and I know I keep saying that things might change after vaccine implementation begins, but important to remember that vaccine trials excluded transplant recipients. So kind of data about how that will perform will really lag behind data for other groups. But just kind of to summarize what we've talked about, COVID-19 pandemic has obviously led to really large reductions in kidney recovery utilization, but these appear to have started to recover. Kidneys from donors with active COVID-19 should not currently be recovered or transplanted, although this is not really an evidence-based recommendation and might change over time. Kidneys from donors with recovered COVID-19 can be used at least 21 days after initial infection if the donor has achieved symptomatic resolution. And asymptomatic donors without known COVID-19 should undergo at least one, probably two PCR screens within 72 hours of donation. And if they can do that, at this time, it appears that donation is safe. Thank you to the organizers. Thank you to all recipients. I hope everyone's staying safe out there. If you have any questions or would like to discuss any of this further, here's my email address. If you want to discuss in a more public forum and involve other people, happy to discuss over Twitter as well. Hope everyone remains safe, and thank you so much for your time.